Thailand is a lower middle income country in Southeast Asia with a population of 67 million. 66% of the population is rural, concentrated in the rice-growing areas of the central and northern regions. Thailand has outperformed many other countries at a similar level of national resources in improving health outcomes. By the 1990s, interventions essential to child survival and maternal health, notably free antenatal care, skilled birth attendance, family planning and immunization, had reached universal coverage. Despite continuing challenges of geographical inequity, Thailand's health gains have been achieved in conjunction with reductions in the rich-poor health inequity gap.
ความยากจนลดลงหนทางคมนาคมเนี่ยดีขึ้นการกระจายบริการสุขภาพต่างๆเนี่ยดีขึ้นและใช้วิธีการที่ถูกต้องเช่นการใช้ ORS นะฮะใช้ Growth Chart นะฮะขององค์การอนามัยโลกเนี่ยในการแก้ปัญหาภาวะโภชนาการนะฮะทำให้ทุกอย่างดีขึ้นหมดครับ
Between 1975 and 2005, life expectancy in Thailand increased markedly, and the total fertility rate fell significantly between 1965 and 2003. Infant mortality has fallen sharply between 1970 and 1991. By 2006, it had reached under 10 per 1,000 live births.
Thailand has made enormous strides in developing and achieving universal health coverage with its 50 baht scheme. It's rolled out a program that now enables the entire population to receive health care.
By the early 2000s, Thailand had achieved all Health Millennium Development Goals, or MDGs. It then introduced the concept of NDG+, a set of country-specific targets going well beyond the international targets.
MDG Plus เนี่ยก็เพื่อที่จะมุ่งเน้นการเข้าถึงนะฮะของกลุ่มคนที่ด้อยโอกาสนะด้อยสิทธิต่างๆนะฮะเช่นประชาชนใน3จังหวัดชายแดนภาคใต้นะฮะยังมีคนจำนวนมากที่อาจจะยังไม่เชื่อในระบบการคลอดนะฮะของการแพทย์สมัยใหม่นะฮะยังมีความเชื่อดั้งเดิมนะฮะไม่ยอมเข้ามารับบริการนะฮะ
By adopting goals and targets that are customized to local needs and priorities, MDG Plus has become a central theme in Thailand's multi-sectoral human development movement. So how did Thailand manage to achieve significant health improvements at relatively low cost in terms of total health expenditure per capita and percentage of GDP devoted to health? This was the question posed in the Good Health at Low Cost book edited by the London School of Hygiene and Tropical Medicine and sponsored by the Rockefeller Foundation.
Health system development is one of the key contributions for health improvement among Thai people. Health system development will ensure that the needed health care is accessed by people adequately financed. There are doctors and nurses and other paramedics there. So this we have to ensure that not only health system development, we have to make it functional. Not only functional for people who are the elite in the urban setting, we have to make sure that the poor in rural areas have equitable access to health services.
Like all of the countries achieving good health at low cost, one central feature of Thailand's success has been strong leadership on many levels.
We have seen individuals who really have made a difference. A willingness by leaders, by governments to reach out to all of their people and not just a particular ethnic group, then you do see much more progress being made.
Health has been included in policy statements by almost all Thai prime ministers since 1942. Although politicians determined and set elements of the health agenda, they had rapid turnover. Between 1970 and 2000, unseen but crucially important technocrats with long-term institutional memory and exposure to rural health and public administration were promoted to high positions in the Ministry of Public Health. They had strong direct and indirect influence in convincing politicians to endorse a number of key elements of the national health agenda.
ด้านสุขภาพของประเทศไทยเนี่ยประกอบด้วย3ภาคส่วนนะครับอันหนึ่งคือภาคการเมือง2ภาคข้าราชการและ3คือภาคประชาสังคม ประเทศไทยเนี่ยมีการขับเคลื่อนในทั้ง3ด้านนี้ควบคู่กันไปนะฮะโดยที่ประเด็นด้านสุขภาพนั้นเป็นปัจจัยพื้นฐานที่สามารถการเมืองนี่หาเสียงได้นะครับ
In Thailand, you can identify really expert public health doctors at all levels who were key in the policies to achieve health improvement. And so that technocratic level is really important. But I think it's also important to recognise that they need political backing, that they can't do everything on their own, and therefore a political level that gives priority to health is absolutely critical as well.
The royal family, too, through royal health projects, contributed to comprehensive rural development, not only improving health but also empowering rural communities.
Their royal family has been very concerned about the poorest, and indeed Prince Mahidol, one of the members of the royal family in the 1920s, trained in public health at Harvard and then went to a remote rural hospital to practice medicine there.
This emphasis on improving the health of the poorest was a vision shared by many in Thailand, which ensured that pro-poor, pro-rural health policies remained the priority of health system development. This shared vision, in turn, resulted in a 5-year national health planning process that has been renewed no less than 9 successive times over the last 4 decades. What has come out of these 5-year plans are another key factor in Thailand's ability to achieve good health at low cost. Effective communication and feedback loops between policymakers and implementers fostered a high degree of integration and the successful implementation of policies, in many cases avoiding national vertical programs. However, innovations were not possible without flexibility and implementation capacity at local level.
At the provincial level, the provincial chief medical officer is the implementers of national policies. So they are appointed by the ministry. At the same time, at the district level, the district health officers and hospital director are the implementers of this national program in translating. They are responsible in translating policy into a micro level implementation according to their local specific situations.
Health managers at provincial and district levels were capable of translating national policies into successful programs.
What are their functions? They are managing resources, make sure that resources are available at the right time to the right place and deliver products.
Further along the rural health system infrastructure are the nurses and public health workers. They are multi-purpose and are well trained to serve the community in particular public health functions, such as health promotion services, preventive services, and other community-based health services, for example, school health and home visit. Some professional nurses have 1-year post-service training as anesthetic nurses and conduct local and general anesthesia in district hospitals, including for caesarean sections and other obstetric emergencies.
In my perspective, nurses are the backbone of the health system because they are outnumber of doctors. They come mostly from the local areas. They are trained as a nurse. Also, other public health officers, they are more engaging in district and sub-district level services. So they are backbone in translating, in providing health services.
Nurses in district hospitals also provide the first antenatal care visit, and they are also trained to provide counselling for HIV/AIDS in pregnancy, offering advice about prevention of mother-to-child transmission. Nurses and public health workers are also major providers of family planning services and, in some cases, responsible for normal, uncomplicated deliveries.
Nurses and public health workers are playing a critical role in ensuring that maternal and child health are accessible by the people. They provide services in health promotion unit of the district hospital, or they provide service in the health centers. And this service may cover antenatal care, family planning services, outreach of family planning services.
Another major achievement in human resources for health in Thailand was mandatory public health service for all new medical graduates, which began in 1972.
นักศึกษาแพทย์เมื่อสำเร็จการศึกษา6 ปีแล้วเนี่ยบัณฑิตแพทย์ทุกคนนะคะก็จะต้องใช้ทุนการศึกษาโดยการกลับไปทำงานที่โรงพยาบาลในชนบทนโยบายนี้เริ่มมานับถึงวันนี้ก็เป็นเวลา40 ปีนะคะนโยบายการชดใช้ทุนหลังการสำเร็จการศึกษาเนี่ยก็ขยายไปถึงทันตแพทย์เภสัชกรแล้วก็บุคลากรสาธารณสุขอื่นๆด้วยค่ะ
Historically, nursing faculties in universities under the Ministry of Education were unable to produce the number of nurses and midwives needed to meet demand for scaling up Ministry of Public Health rural health services. In response to this challenge, in 1961, the ministry established its own nurse and midwifery colleges, which were licensed and certified by the Thai Nurse and Midwifery Council.
นั้นตรงนี้ก็เป็นประเด็นที่ตัวกระทรวงสาธารณสุขเองเมื่อมีความจำเป็นที่จะต้องขยายโรงเรียนพยาบาลเนื่องจากมีเป้าหมายว่าจะรับเด็กนักเรียนจากชนบทเข้าเรียนและเมื่อสำเร็จการศึกษาแล้วให้กลับไปใช้ทุนที่บ้านเกิดก็จำเป็นที่จะต้องมีนโยบายอันนี้นะคะแล้วก็กระทรวงสาธารณสุขเองก็หลีกเลี่ยงไม่ได้ที่ว่าเด็กเนี่ยก็จะต้องเป็นไปตามมาตรฐานที่กระทรวงศึกษากำหนดหรือมหาวิทยาลัยกำหนด
In 1982, a policy was introduced to produce a 2-year training diploma for technical nurses. After a few years of mandatory rural services, these technical nurses completed an additional 2 years of post-service training, after which they were upgraded to professional nurses. Producing more nurses eased the huge service loads in the public sector.
นั้นจำเป็นที่จะต้องมีบุคลากรระดับวิชาชีพเนี่ยดูแลประชาชนนะคะโดยเฉพาะอย่างยิ่งในพื้นที่ชนบทห่างไกลที่ขาดแคลนแพทย์พยาบาลก็จะเป็นบุคลากรกลุ่มแรกที่จะต้องดูแลประชาชนเป็นเบื้องต้นเพราะฉะนั้นความรู้ความสามารถของพยาบาลจำเป็นที่จะต้องมีอย่างเพียงพอนะคะที่จะดูแลสุขภาพประชาชนค่ะ
In general, health programs have been well received by villagers and communities. Most of this confidence comes from the close proximity of the doctors, nurses and public health workers to the rural population.
Trust come from people experience that they can actually use the services and they have confidence that the services provided are of good quality.
One unique feature of the Thai health system is its extensive and long-term investment in a healthcare delivery infrastructure that reaches even the most rural and remote areas.
Today, I would say most of the people in remote areas have been able to reach services within decent time of traveling, half an hour or not more than 1 hour. In the island area, we have also a mobile service in both mobile clinics.
Expansion and upgrading of health facilities took 25 years, from the first 5-year National Health Plan until full coverage at all district and sub-district levels by 1990. The first plan laid a solid foundation by expanding the number of provincial hospitals to at least 1 in every province, and later plans did the same for district hospitals.
ตั้งแต่ 2518 ที่มีรัฐบาลมาจากการเลือกตั้งเนี่ยรัฐบาลสมัยนั้นก็ประกาศที่จะให้มีโรงพยาบาลทุกอำเภอในประเทศไทยนะฮะอันนั้นก็ในที่สุดเนี่ยเราก็สามารถที่จะมีบรรลุเป้าหมายได้ในณปัจจุบันนี้และไม่เพียงแต่โรงพยาบาลอำเภอเท่านั้นแต่เรามีสถานีอนามัยครบทุกตำบลในประเทศไทยนะครับอย่างนี้เป็นต้น
Rapid scaling up of district hospitals began in 1977, and the next 2 decades witnessed a double-digit growth in their number until every district had full coverage.
So a district health system consists of 10 health centers and 1 district hospital. Today, and they are working as a team.
This expansion of the district health system was critical. It laid a firm foundation for the future scaling up and equitable distribution of essential public health interventions and health services needed to achieve good maternal and child health outcomes. Increased incomes, education, and growth in the country's infrastructure meant that Thailand's health service needed to be financially accessible to everyone. Innovations on financial risk protection and universal health coverage, although unique to the country, became critical to improving its people's health.
It is unique because government has strong intention to provide financial risk protection, ensure that patients has financial access to healthcare. This will ensure that the poor have access to services free. And later on, they expand the scheme to cover the elderly more than 60 years old, cover children more than below 12 years old, and other disabled people and other social disadvantaged groups.
In 2001, building on the development of previous decades, the government decided to introduce universal healthcare coverage for the private employee, known as UC. This was achieved in 2002 when the entire population was covered by one of the three insurance schemes: the existing social health insurance, the civil servant scheme, or a new scheme for the remainder of the population.
Since the general election in 2001, the Thai led by Thaksin, Prime Minister Thaksin, won a landslide votes. He formed a majority coalition government and make a strong decision that Thailand will go with universal concept, no more targeting approach. Then by 2002, all 64 million people were fully covered by either the UC scheme or the government employee scheme or the social health insurance scheme, fully covered.
A significant result of the extension of financial health protection was the reduction in both household out-of-pocket payments and catastrophic payments for health care among the poorest.
Namely, the benefit package is very comprehensive, cover outpatient, inpatient, high-cost care, chemotherapy for cancer treatment, main surgical interventions, including medicines, free at-point services. This results in a very minimal level of household payment, less than 20 baht per household per month. This very minimal payment result in protection of the household being poor because of the medical bills. So that's we call preventing health impoverishment.
There are many factors that help to achieve improved health at low cost in Thailand. Economic growth, especially in the 1990s, allowed governments to improve roads and communication, gave people access to clean water and nutritional food, and encouraged increased literacy amongst the poor, particularly women.
Other main contributing factors are female adult education. In Thailand, women have been empowered, their rights and their opportunities were realized by having equal opportunity for education to access to care. For example, female adult literacy rate will ensure that their kids are being taken care when they are ill. Transportation, economic development also have a major enabling factors. Better access geographically to health services are so important. I would say increasingly Thailand become advanced democratic society whereby civil society play increasing role in ensuring that health is one of the key policies, national health policies, ensuring better access to care by the people.
Thailand has come a long way over the last few decades. Like the other countries featured in the Good Health at Low Cost book, it is not perfect and still has a long way to go. But Thailand has undoubtedly shown that good health at low cost for the majority of its population is possible. It has clearly got some unique features that enable this, but there are also many things that others can learn from and use for themselves.
Thailand is a very interesting example because Thailand now has universal coverage. That means all its citizens have access to healthcare. And yet that policy was put in place shortly after the major recession of the late 1990s. And Thailand did not allow the recession to stop it in its plans. And I think that's an excellent example for others to follow.